Fine. So, good morning, everyone, and this is Dr. Munjal Pandya, and welcome to our this company Medical MCQ for all. For those students who are joining the first time, it's a little quick review, right? Preparing for all Middle East country exams like DHA, HAD, MOH, OMSB, SMLE, QCHP, NHRA, KMLE. So almost all Middle East country exams we are giving the coachings and everything. This is our key area of interest. What we provide exactly. So we are providing one excellent book that is called PROMETRIC 1000 MCQ book, which is available in hard copy as well as ebook is also available. Right, this hard copy is recently updated, right, almost like 3 months back. So this is updated version, right? So you can get it if you wish. You can order it online. Second thing is online subscriptions and coachings we are also providing, right? So this online subscriptions and coaching, and this is a live daily coaching. So what we are doing is a live class, right? It's not recorded. So live class we are conducting every day by subject expert, by gynecologist, pediatrician, surgeon, myself, hemato-oncologist. So this is excellent, especially for those doctors who are, appearing for second or third attempt. Probably you need little more intensive exercise and practice and clarify your concept to crack the exam in second or third go. So we usually recommend beyond the second trial. WhatsApp subscription is also there. Oman Viva coachings as well as online subscription is also we provide. We provide all data flow services by Dr. Anjali is there in Dubai. So Dr. Anjali is the head of data flow. She is based at Dubai permanently. So you can contact her. Her number is also there in this slide. There is again one short that is a one of the best so far we created in medical MCQ. It is 100% guaranteed. If students fail, money back. That's it. So this is short package is also there, and there are mobile application on Android and iPhone. So those who are using our subscriptions and various facilities, they can download the mobile application either on Android and Apple or iPhone. It's available on both the platforms. So you just need to download. You can completely access the whole website from the mobile as well. This is myself, Dr. Munjal Pandya, not going much in detail just to save the time in the quick. I'm a MBBS and did fellowship in hematology, oncology, and bone marrow transplantation, practicing close to 20 years now, treating the blood disease and cancer patients, and more than 10 years of teaching experience and treated more than 100,000 patients so far. So probably my experience will help you today to crack many MCQs. This is Dr. Aarti, our team member. She is a gold medalist, consultant pediatrician. Dr. Maddie, she is also internal medicine. She is also taking regular class. Dr. Shikha Garg, she is a consultant gynecologist. She is shortly moving to Dubai, right? And she is in our team. So she will guide you from Dubai as well. Dr. Ankit Patel is a consultant gastroenterologist also in our team, and there are a lot more teams. Dr. Meghna, Dr. Ankit, Pallavi is our support manager and all. This is our contact details, so you can approach us on this number. As I told you, this is the latest updated book for medical MCQ for all, right? So it is almost this 1000 MCQ, right? This is high yield 1000 MCQ. So you can, if you are interested, you can order it. That's it, right? So that's the things. And last but not the least, coaching, right? So right now the coaching is absolutely the cost of the coaching is 500 USD, but now almost 50% discounted for last couple of months. You just need to apply one code coaching 50, so you get a 50% discount. You can approach to Pallavi or just enter directly by your own. You can get it directly. 50% discount on the coachings as well. That's it. Data flow, as I told you, Pallavi is Anjali is our support team. She is the head data flow. These are the number of Anjali. She is based at Dubai, so she will guide you for complete data flow, exam booking, center, right? All the logistics and questions related with the data flow. Directly contact Dr. Anjali, right? She is also a general practitioner and based at Dubai. And my numbers are, I think, with almost the people. New mock test. This is a recent module we updated on the website. Modules added on the website. Use it and you can track complete records. So try to use it. It is an excellent tool we created recently last month. Right, whatever the mock test you are giving, you can monitor your score. Right, how you are doing in last month now, what next month, what. So you can completely track your record and your progress by just one click, right? And you don't need to remember when you had given the test, what was the score before 1 month. what were the right questions and wrong. Absolute all statistic will pop up in a just one click on the things, right? So if you need any help or if you need anything else, just do let me know. So I will guide you for sure. Or you can contact Pallavi. She will guide you for mock test. Another good news is that we are coming up with the two new modules, right? One is as I told you, EMRI. EMRI is a exam. Few people doesn't know what is EMRI. So EMRI is Emirat Medical Residency Entrance Exam, right, in UAE, right? So EMRI exam is we are shortly planning to start the course, right, online, right, and we are launching probably in the mid of July or end of the July with Dr. Afrin is a counter partner based at Dubai. So she probably comes end of the lecture and give you the 5 minutes about the idea. Those who wants to do the post graduation in Dubai, right? What are the criteria, how to do, what's logistic? There are a lot of hundreds of questions with Emory, right? So basically, it's a residency exam, post MBBS exam, post medical graduate exam, right? So if you want to pursue gynecology, pediatrician, emergency in Dubai, this is the exam you need to crack. This is the entrance exam, EMRI, Emirate Medical Residency Entrance Exam. So Dr. Afrin will shortly join maybe end of the lecture, so she will guide you quickly. And dental UAE exam, so far we have no dental exams, material, study material coaching. So shortly we are starting this. So that's it. This is what the thing is. So let's come to the main subject. Everybody get ready. Now it's exactly the 11 o'clock. So we'll start this. I'll give you the 15 seconds after each question, right? You need to think. Don't be in hurry. These all questions, believe me, compiled in a such a way, excellent explanations, right? And if you concentrate well, you really get to know the idea how to prepare, how to crack, how to interpret, right? Probably it could be a excellent new experience for you today because the way you are preparing and the way I am guiding you as an expert will have a big difference, and this will help you a lot. So just concentrate on the questions. You can post your answer in the chat box. We'll discuss one by one. I'll tell specifically some names so you can interact with me.
लैपटॉप ही मत
This absolutely a
ठीक है ठंडा
bilateral conversation.
स्ट्रांग खा जाए
One, one request, that a lot of
खीर घट with जाए उनमें
I don't know why did the I muted all. If you want to unmute yourself, you can unmute from the below, right? So I muted all because I don't have individual button. Okay, that's fine. So let's start with the first questions in front of your screen. A 53-year-old male with past medical history of IgA deficiency and diverticulosis presents with lower GI bleeding and found to have acute blood loss anemia. Several minutes after starting a blood transfusion, he becomes agitated. On examination, patient has a tachycardia, fever, hypoxia, hypotension, wheezing in the bilateral lung fields, tongue
ओके
is
सर
swollen. There must be some kind of hypersensitivity because if you concentrate on the history, several minutes after starting a blood transfusion, he becomes agitated and all problems start after starting the blood transfusion. So something wrong. So what are the options? Is it type 1 hypersensitivity reaction? Is it type 2 hypersensitivity reaction? It's type 3, type 4, it's none of the above. You have 15 minutes, your time starts now, and consider this all questions comes in
मतलब
exam,
भैया
so I
साउथ
would be
मतलब
happy
साउथ
that you can answer. I muted all. I don't know what this gentleman is doing. Yeah, so post the answer. I mean, if you keep quiet, doesn't solve the problem, right? So you post the answer in the chat box, whatever you think, one, B, A, B, C, D, E, whatever, right? Because think that if the same questions comes in your exam, how you respond, right? And this is all absolutely high yield questions. I try to prepare, right? So that will give you a good idea, right? So no need to worry whether my question is right or wrong or right. Yeah, so let's discuss. Let's discuss with Dr. Mitu. Dr. Mitu, what do you think? Why this is a type 2? What is type 1, type 2, type 3? Now you can unmute your mic now. Dr. Mitu's iPhone. You joined as a Mitu's iPhone. Yeah. Any comment, Dr. Mitu? Discuss. Don't worry. Right, wrong, it's fine. That's fine. Everybody. This is a learning
Yeah, but
platform.
I think it is hypersensitive. It is hypersensitivity reaction only.
Okay, fine. This is hypersensitivity, obviously, but I
Yeah.
need to know whether it is type 1, 2, 3, 4. As per what you posted your answer in the chat
It
box,
is
I
not
can
a
see.
mild. It doesn't seem mild to me. It is slightly on the higher side only. So I thought it is B.
Okay, so how you categorize type 1, type 2, type in terms of severity of the symptoms or
No,
in
I have
terms
no
of the immune
idea.
reactions in the body, or I mean just trying to understand. You understand?
No,
Fine,
I'm
no
really.
problem. So just wait for the real
Yeah,
answer, right? Because this is
yeah,
all high
yeah,
yield, right?
yeah.
And wherever you feel that you need to ask, feel free to ask because this is the
Sure.
best platform where you can clarify your concept. Yes, Asmat Dennis. Any idea, Dr. Asmat Dennis? Dennis, what kind of hypersensitivity by your means? You can unmute Dr. Asmat. Dr. Ajdani. Dr. Ajdani, your answer is C, type 3 hypersensitivity. So I want to understand what is type 1, type 2, type 3, type 4. Okay, Dr. Manj DR CH Vikram Reddy. Yes, what's your answer?
Sir, I think the answer is type 2 hypersensitivity reaction.
Type 2 hypersensitivity.
Uh,
So how you define type 2 hypersensitivity reaction?
Type 2 is cytotoxic. It is antibody mediated.
Okay, cytotoxic
So,
and antibody mediated. Okay,
since blood transfusion is happening here, it could be a mismatch and it could be antibody mediated. I feel so, sir.
okay, fine. Dr. Talat Munir, let's see, just we discuss in 1 minute. Somebody raise
Hello.
the hand.
Yes, sir.
Yes, yes. What's your
Yeah, can
opinion,
you
sir?
hear me, sir?
Yes, yes, very well. Your voice is very nice. Go ahead.
Yes. So this is type 2 hypersensitivity reaction because since in the history we have the patient is IgA deficient. So this patient already has anti-IgA antibodies most probably. So if the blood is given without if he receives a normal blood transfusion which has IgA, so the patient will be it's basically a immunity transfusion reactions, and that is an
Mhm,
antibody mediated reaction and type 2 hypersensitivity.
mhm. Fine. So this is the real picture. This is the real picture. Later on, you can answer the things. Type 1 is IgE mediated. I'll explain everything. Don't worry. Type 2 is IgG and IgM mediated. Type 3 again IgG and type 4 is T cell mediated. So there are four types they categorize in medical science: type 1, type 2, type 3, type 4. Type 1 is what exactly? IgE, right? There are five types of antibody: IgG, A, M, D, and E. So those who don't know what kind of antibodies are there in plasma, there are five types of antibody: IgG, IgA, IgM, IgD, IgE. So this is type 1 is IgE. What's the IgE? It's a IgE mediated. What does IgE cause? It cause activation of mast cell and basophil. What the substance inside the mast cell and basophil is a histamine and leukotrienes. So that gets released in the blood, and because of that, there is a urticaria, there is a angioedema, and there is a anaphylaxis. Right. So this will happen in the patient, and the real this example of this is a blood transfusion, right? So this is a type 1 hypersensitivity, immediate hypersensitivity within few hours. They are saying, right, the several minutes, not even hours, several minutes after starting a blood transfusion, he became agitated. It's there. Tachycardia, it's anaphylaxis. Hypoxia is a part of anaphylaxis. Hypotension and wheezing is absolutely classical case of anaphylaxis. And anaphylaxis is a classical example of type 1 hypersensitivity that is mediated by IgE. Can anyone tell me what could be the treatment of this patient? If this patient, after starting the blood transfusion, if somebody comes to you within 10 minutes, hypotension, tachycardia, hypoxia, patient has a bilateral wheezing, rhonchi, patient breathlessness, respiratory rate went up to the 35, 36, what could be your first line of treatment
Stop
for this?
the infusion.
Excellent. So
Yeah.
stop the infusion because that is a culprit. Okay, fine. You stop the infusion. What else you will going to give to this patient in terms of
IM
medication? Because
IM epinephrine.
excellent. So this is the IM epinephrine. IM epinephrine. Epinephrine and adrenaline is same. So there are a lot of doctors, those who gets confused between adrenaline and epinephrine. So don't get confused. Both are the same thing. It's the name is different, right? So you stop the transfusion, you give the epinephrine, then you give the antihistamine and whatever you want to give, right? Blah blah. That is. But first and foremost, drug anaphylaxis again a different MCQ in the exam. So what is the key fact things? whatever the culprit, if it is a blood, stop the blood. If it is chemotherapy, stop the drug. If it is levofloxacin or some sulfur drug, stop it. So stopping the things in anaphylaxis is the first thing, and then you need to reverse the pathophysiology, right? Mainly when there is a cardiorespiratory involvement in anaphylaxis, right? So if your heart rate is going up, your blood pressure going down, your respiratory compromise, hypoxia, tachycardia, tachypnea means cardiorespiratory involvement due to anaphylaxis, you must give the epinephrine. You must give the epinephrine. Lateral wall of thigh, that is the most commonest site you need to give, right? So you give there is a EpiPen. When I was in Dubai, there was a EpiPen available. There is a some pen, like, right, like a ball pen. So there is a ball pen. It is called EpiPen, epinephrine with pen. So you just need to inject into the lateral wall of thigh. That's it. So your job is done, right? So this is a type 1. Let's understand what is type 2. Somebody told me cytotoxic reaction. I forgot the name. So cytotoxic reaction. Cyto means cell and toxic means cell, toxic to the cell. That is cytotoxic reaction. IgG and IgM mediated antibody. So this IgG or IgM antibody binds to the cell, right? So this antibody binds to the cell, and they release, right, and complement and cell rupture, right? And they do the cell rupture. So cell means cyto, toxic means toxic to the cell. So here, right? So the difference between type 1 and type 2 is that type 1 acts in a different way. It is not toxic to the cell. It is not cytotoxic. Type 1 is IgE bind to the basophil and mast cell, and then this basophil and mast cell will release profuse amount of histamine in the blood, and that is why you get angioedema and anaphylaxis. It's a different mechanism. Here, what's the type 2? Cytotoxic reaction means antibody binds directly to the cell or the surface of the cell, and it activates the complement and do the cell rupture. So it's a cytotoxic. It is killing. It bursts the cell. There in type 1, it doesn't burst the cell. It releases some chemical in the blood which causes the pathophysiology. So that's type 2. What are the example of type 2? Blood cell dyscrasia, hemolytic anemia. So this is hemolytic anemia, right? I mean, in hemolytic anemia, this type 2. Autoimmune thrombocytopenia. So autoimmune thrombocytopenia, you may get probably in the ITP, right? We'll discuss couple of questions. ITP, immune thrombocytopenic purpura, where what happen? IgG or IgM bind to the platelet, break down the platelet. There is a fast destruction of the platelet, type 2 hypersensitivity. Type 3 again is an immune complex formation. Here what happens? Antigen and antibody, they make a complex and they get deposited in the several parts of the body like skin, kidney, joints, liver, GI tract, and that is vasculitis or serum sickness, type 3. And type 4 is absolutely different. 1, 2, and 3 is antibody mediated. This is a T cell mediated T. There are two type of lymphocyte in the blood: T lymphocyte, B lymphocyte. T lymphocyte cell mediated, and B lymphocyte develops the five types of antibody, right? That is called humoral antibody. T cell is a cell mediated antibody. So type 4, sorry, it's a delayed usually, right? So after several minutes, hours, or days, you develop this, right? So delayed cell mediated hypersensitivity reaction, T cell mediated, can be further divided. So no need to remember, but it's a T cell is a, uh, I mean, type 4 is a T cell mediated, and allergic contact dermatitis, right? So there is a local inflammation, local infiltration of the T lymphocyte and cause dermatitis, SJS, Steven Johnson syndrome, right? So that is also a type 4 hypersensitivity reaction. So that's all. I conclude my first question. Let me tell you one thing. Don't feel bad about my this statement, what I'm going to tell you. If your score is less than 50% today, check your score. So this is one question. 1 out of 1, if his answer is correct, 1. If your answer is wrong, 1 out of 0, 2 out of 0, 2 out of 1, 3 out of 1, 0, whatever, right? So you just monitor your score. If your score is less than 50, absolutely not good idea to go for the exam now. This is my general statistic of last few years, right? If your is 50 to 60%, still you need a good preparation. Here you need at least 3 months of preparation. Here also roughly close to 3 months preparation. 60 to 80, probably within 1 month you are ready to go for exam, and more than 80% of score today, anytime you are ready to go for exam. This is general statistic, not applicable to any individual. It's in general basket statement, but you need to monitor what's your percentage of score is today, right? So depends on that, you decide yourself that how worth to go and how fast to go. So don't be in hurry. Try to understand the things and go it. So you monitor your score, right? This is one question, whether you posted right or wrong. We'll switch. So this is all we discussed already in the explanation. Jumping to the second question, concentrate on it. A 8 months old male boy with a history of severe eczema, recurrent infection, present with a new patchy rash and blood in the stool, bloody stool. Labs are significant for the thrombocytopenia in a deleterious mutation in VAS gene. What is the most likely diagnosis? Is it von Willebrand disease type 3? It is Wiskott-Eldridge syndrome. It is Chuck-Strauss syndrome. It is D-George syndrome. It is none of them. Your time starts now. Take 15 minutes, 15 seconds, 20 seconds. Nothing to hurry. We have more than 35-40 doctors in the group, but still I'm getting answer 2 or 3. So try to post the answer. Don't worry about right or wrong. Because you need to do some brainstorming, na? You need to understand what exactly is going on. Then you get to know that, okay, fine. Quick, quick. Only just 3-4 answers. So far, I got it in the group. Yes, Dr. Shibu Thomas, any comment? Dr. Shibu Thomas, any comment? Anyone? Anyone in the house, any comment? Great, wonderful. So you posted in the chat box. That's fine, not a problem. Great. Dr. Sandra, Dr. Sandra, what's your answer? Dr. Sandra, anything you want to discuss? Why this is D? Why it is D, George? You can unmute
Because
and you
the
can
George syndrome includes nephrotic symptoms.
Sorry?
The George syndrome includes renal symptom.
So this is not a D George syndrome, doctor, because in D George you will not going to get a VAS gene, WAS gene. This is a VAS,
Yeah,
Wiskott-Eldridge
it
syndrome.
includes Wiskott
This is how it comes, right? So answer here is a Wiskott-Eldridge syndrome. What is this? Wiskott, uh, right? Wiskott is the name of the person who invented this. In 90s, I was evaluating today how does Wiskott-Eldridge syndrome name comes. So when I was evaluating the literature, there was a German pediatrician whose name is Wiskott, right? So he is seeing lots of pediatric patients and he has a lot of patients like this. So then he evaluated and eventually the name came as a Wiskott-Eldridge syndrome. So there are 3 pathologies in Wiskott-Eldridge syndrome. One is the eczema, which is there in the scenario. So let me give you the idea of what is the things. So see here, new petechial rash is a eczema basically, right? Second thing is a thrombocytopenia, microthrombocytopenia or small septate platelet, that is a thrombocytopenia. Here the thrombocytopenia is also there in this scenario. If you can see, thrombocytopenia is also there. So second feature is also there, and there is a bleeding because of thrombocytopenia. There is a bleeding, right? Severe eczema, again that is a skin related eczema, and recurrent infection, So this is a triad. So 3 things you need to sue: eczema or skin things, right? Second is a thrombocytopenia or low platelet count or thrombocytopenia, and third thing is a recurrent infection. That's it. So these are the classical triad, and when you have a 3 genes, you're going to go for one gene detection in the blood, Wiskott-Eldridge syndrome. This is how the VAS gene comes in the picture, right? So you need to look for the VAS gene. If the all things are matching, what your next step is to do the VAS gene, right? So if the VAS gene is present, your diagnosis is Wiskott-Eldridge syndromes. What happens in von Willebrand disease when you are doing the questions? I again told you earlier many times, you need to do the triad. This, never forget this triad for any MCQ. From today onward, if you discuss or if you solve by your own any MCQ, you need to know the 3 things. Diagnosis, what's the diagnosis of this scenario? So they are asking the diagnosis. So diagnosis is done. Second is investigation, how you investigate and what's the treatment. So investigation, right? You are suspecting Wiskett-Aldrich. What you are doing, was gene, right? So this is also you have done. Now you have to think of the treatment, though it is not asking that, but every MCQ you must keep this triad in mind. What is the diagnosis of this MCQ? What is how you investigate and or reach up to the diagnosis, and what is the treatment? So if you develop the master in this, right, of developing this, right, you will going to get these things right very well. So you need to keep in mind. Sorry, something went wrong. Let me 1 second. Sorry, 1 second. Okay, is my screen is visible?
Yes, yes.
My screen is visible, sir.
Yes, yes.
Okay, great.
Yes, sir. Yes.
Yeah, something went wrong. So this was I was discussing is a Wiskott-Aldrich syndrome, right? So this is nothing, I mean, very difficult questions, but we need to know what is the basic of the Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome, there are three things, right? As we prophylactic antibiotic, why the prophylactic antibiotic? Right? Because there is a recurrent infection, right? So a recurrent infection is there, so we need to give the prophylactic antibiotic to most of the patient. Platelet transfusion because of thrombocytopenia, and transplant is basically the ultimate treatment. There is a one dictum I got it very important is water. If you remember the water, WATER, WA stands for Wiskott-Aldrich, and TER, T stands for thrombocytopenia, E stands for eczema, and R stands for recurrent infection. So this is little easy for you to remember. Water, Wiskott-Aldrich syndrome, water. Wiskott-Aldrich with thrombocytopenia, eczema, recurrent infection. That's it. So this is what the thing is. So let's come. Now you need to know what's your score. So you know the score, right? What's your score, right? So don't get scared of your score. What is the score of you out of two questions? How many right? How many wrong? You just need to know. Third questions in front of your screen quickly. A 19 years old female present with a vaginal discharge and dysuria, young female with vaginal discharge and dysuria, examinations of mucopurulent discharge and cervical motions tenderness on lab, nucleic acid amplification test, NAAT, that is nucleic acid amplification test, is positive for gonorrhea. What's the treatment? Probably it's a straightforward, very simple questions. So basically they are asking the treatment of gonorrhea. That is what I understood. Yeah, so your time starts now. What do you think? What's your treatment? How you treat this patient? How you treat this patient? Yeah, post the answer. I mean, so very interesting questions, no? So basically, this is sexually transmitted disease, and they are trying to ask you the treatment of sexually transmitted disease. So almost, I mean, the complete whole house is correct with the answer. Single dose of IM ceftriaxone. So I'm agreed with everyone. So let me ask you, what could be the organism, doctor? What is the organism? So three things we need to know, right? In any MCQ, as I discussed again, right? So I need to know that the three things, what the three things I need to know for any MCQ is that what is the diagnosis, investigation, and treatment. So anyone can tell me what could be the organism for this?
Gram-negative cocci.
Gram-negative cocci. Could you name the cocci name? Is there any name of cocci?
Neisseria gonorrhea.
Okay, great, wonderful. So you need to know organism for everything, though it is a simple questions, but you need to know, right? You need to know what's the organism, right? For every these questions. Fine, fair enough. So that's perfect. So this is what the thing is. right? So answer is a single dose IM ceftriaxone. So what was the question? What's the diagnosis? Diagnosis is gonorrhea. What's the treatment? Treatment is a single dose of intramuscular ceftriaxone is good enough. Now this is the little fact about the gonorrhea. Let me go very quickly. Certainly, gonorrhea is sexually transmitted disease. The name of bacteria is Bacterium Neisseria gonorrhoeae. Effective treatment is crucial to prevent complication and further transmission. Ceftriaxone is the drug of choice across the globe. Single dose 500 milligram IM ceftriaxone is good enough for uncomplicated gonorrhea and avoid the sexual activity for at least 7 days to prevent spread of infection to others. So once somebody diagnosed, you give the treatment, given the things, try to stop the sexual intercourse for at least 7 days just to prevent. So you are giving injection today doesn't, kill all the organism in a 1 day. You need to have a 7 days period. Doxycycline, when you supposed to add the doxycycline, if the chlamydia infection has not been excluded. So whenever you are doing the gonorrhea, you need to exclude the chlamydia as well. If the chlamydia infection has not been excluded, concurrent treatment with oral doxycycline is also recommended because many a time gonorrhea with chlamydia goes together. So once you eradicate one thing but not other things, then again it may present with some symptoms. And important thing is treat the partners as well, right? So these are the basic concept of things. So single dose intramuscular ceftriaxone and with chlamydia, doxycycline can be used treat the partners as well. So these are the very frequently asked questions in exam. So we end up with the three questions. So check your score: 3 out of 3, excellent score; 3 out of 2, borderline; only 1 and 0 is not good score. But don't get disappointed. You probably win the race later on. A 55-year-old male present with a slowly progressive weakness in the progressive limbs. On examination, he has a hyperreflexia, fasciculation, and atrophy without bladder disturbance. Imaging shows widespread innervation and spontaneous action potentials on EMG, that is electromyogram slash now conduction study. What's the treatment of choice? Is it riluzole, levodopamin, pregabalin with B12, dexamethasone, IV immunoglobulin? So this time, my triad will tremendously help you. Here, what the tricky part is, we don't know the diagnosis. So first, any doctors who are giving me the answer, first you need to tell me the diagnosis, then how you investigate this patient, and third thing is how you treat the patient. So these are the three things, and these three things applicable for every MCQ. So now your time starts now. You try to understand the questions, try to put your answer. Yes, Mitu, any comment? Dr. Mitu? Dr. Mitu, any comment?
No, sir. Sorry.
Yeah, your comment. Yes, Dr. Ajdani, any comment you would like to make, Dr. Ajdani?
Yes, sir. I think this is diagnosis is Guillain-Barré syndrome and treat with immunoglobulin, sir.
Okay, so do you think there is a, GBS or Guillain-Barré syndrome? How the is it hyperreflexia or what? There is a fasciculation you can see the
Sir,
slowly progressive weakness in the limbs,
as
widespread
per I know,
innervation. Can you
sir, this is the descending type of paralysis.
how did you get to know this is ascending type from the MCQ?
In
What's the
GBS, there
clue?
is areflexia. There will be absence of reflexes.
No reflex, right?
Yes.
Yeah, so here the hyperreflexia, it is not areflexia, it's a hyperreflex. So reflex are very high, right? It is a slow progressive weakness, 55 years of age, right? Fasciculations are also there and atrophy as well. And do you think there is in this GBS? Go and read it because this is very frequently confusing questions to everyone. So read three things. One thing is GBS you must read, right? Syringomyelia, read. And third thing is a multiple sclerosis. Read it, go and read it, because this question will 100% comes in exam. Probably I am discussing these questions, but you may get the multiple sclerosis or GBS or something else, or motor neuron disease. So these three, fours are very hot favorite topics for them in exams, and every time we are confusing ourselves. So what do you think, Dr. Ajudani? Is there any action potential, right? What they are saying, imaging shows widespread denervation and spontaneous action potential on EMG and nerve conduction. So, do you think it happens in the GBS?
No,
Any
sir.
idea or no idea?
No, sir.
No, no. So, it's not happen. So, what could be your second diagnosis? If it is not GBS, then what could you think of that it could be the diagnosis, sir?
Is it amyotrophic lateral sclerosis?
Excellent. Excellent. So this is a classical case of a myotrophic lateral sclerosis. So now let's discuss what is that, right? So let me go to the one nice pictures I gathered, right? This is a gentleman. This is very famous celebrity Stephen Hawkins, who was diagnosed as a this ALS, that is amyotrophic lateral sclerosis. What do you mean by amyotrophic lateral sclerosis? A type of motor neuron disease, MND, motor neuron disease, MND. So just go through the literature. ALS is a very rare neurological disorder, progressive worsening with the time with no cure. This is still incurable. Gradually, muscle under voluntary controls are affected. Individual lose the strength, ability to speak, eat, move, and breathe. So breathing difficulty is the one of the biggest cause of morbidity and mortality. They eventually die because of respiratory failure, because muscles. This is motor neuron disease. Motor means motor, sensory and motor. So muscle and neurons disease. So the respiratory muscles are not working right, and they may end up with a respiratory failure. Most people with ALS die of respiratory failure within 3 to 5 years of first symptoms. So when they start the symptoms, within 3 to 5 years they die, because it's a bad disease, right? So that's the things. And what affects the nerve cells responsible for the voluntary controlling the voluntary muscle movement, motor neurons, links between the brains and voluntary muscle. In the ALS, upper motor neuron as well as lower motor neurons, they gets degenerate and patient eventually die, and unable to do the functions, the muscle degenerates. So this is a classical case of motor neuron disease. So motor neuron disease, or ALS, atrophic lateral sclerosis. So we make a diagnosis of ALS, right? We investigated, right, and treatment. So treatment is riluzole, levodopa, right, syndopa, levodopa, right? It is in the Parkinson's disease, B12 with pregabalin, nothing to do with the pregabalin here. Usually given in a diabetic neuropathy, and steroid is not a drug of choice because it's not an autoimmune disease, right? So this is an IV immunoglobulin has as per no much role in these things. So riluzole, what is riluzole? I'll get little bit. Riluzole is a medication used to treat ALS, amyotrophic lateral sclerosis, and other MNDs or motor neuron disease. The right, riluzole delays. What is the most important key things interesting about riluzole is it delays the onset of ventilator dependence because of respiratory failure or tracheostomy in some people, and may increase the survival by 2 to 3 months. Riluzole is available in tablet as well as in the liquid form. That's it. So here the answer is a riluzole. The rest of the things, whatever you can think of, is all symptomatic treatment. And HYF, whenever you see HYF, means high yield effect, right? What's the high yield fact? Classical presentation of ALS is hyperreflexia, stiffness, upper and lower motor neuron is fasciculation and atrophy features, bulbar involvement, tongue or oropharyngeal or cranial nerves involvement, and that's it. So this is a classical presentation of ALS. So that's it. So you finished so far 4 questions. Check on your score. Let's move to the fifth questions. A 29-year-old male is evaluated in the emergency department for syncope. Additionally, he reports a painful burning sensation in his toe and feet for the past few years, particularly after he exercised at gym. He takes no medication. Family history is notable for maternal grandfather and maternal granduncle who had similar burning symptoms for years and died from stroke in their 40s, early 40s, right? So examination, there is a blood pressure of 170 over 98, irregular heart rate, presence of severe angiokeratomas, around umbilical areas, and lab shows EKG, that is electrocardiogram, which shows ventricular hypertrophy. TTE, that is a transthoracic esophagoscopy, transthoracic echo, which shows concentric LVH, that is left ventricular hypertrophy, but the ejection fraction or EF is normal. BUN and creatinines are elevated. Urinalysis shows protein and blood. What is the diagnosis? Little long scenario. Let me tell you one thing. Never practice one-liner MCQ whenever you are doing alone. Same questions will come from DHA, HAD, MOH, OMSB, KMLE, SMLE, you name the exam, USMLE. All the scenario-based questions will come like this. So don't try to adapt a easier way of solving the MCQ. It would be easy while you are solving at home, but in the exam you see such like a long scenario, which is a scenario based. So try to do the practice. Don't get scared of it. More the practice you do, more the comfort level you will get. So what the things, this is the scenario. Again, reading, 29 years male, emergency department came with burning sensation in limbs, particularly after exercise. Same family history, hypertension, heart rate is high, right? And on EKG, you see left ventricular hypertrophy with there is a renal impairment in terms of BU and creatinine elevated. What's the diagnosis? Is it Fabry's disease? It's a Lyme's disease. It is amyloidosis. It is multiple myeloma, or it could be something else. So you need to tell me three things: what's the diagnosis, how you investigate, and what's the treatment. The time starts now. Take your time. Take your time. Yes, Sultan. Yes, Sultan.
Yes, Fabry.
Yes, Sultan. That is Bahar Toprak Sultan. What's your
Yes,
comment?
yes, I am Mahar.
Yeah, what's your comment, doctor?
Actually, this patient has
Let me
pancreatin
go to the
valve.
let me go to the MCQ. Yeah, so you can little.
Oh yeah.
Yeah.
Um, is is angiokeratoma, is skin disease, and renal function disturbed, and a cardiac problem, and um, nervous system problem is included just Fabry.
Fabry.
Yeah.
Okay. So what's
Excuse
the
me, sir.
Yes, sir. Yeah, you can
Sir,
discuss, no problem.
yeah, sir, this is the X-linked autosomal lysosomal disorder, in which
Okay.
it is a Fabry's disease, and in
Okay.
which there is a lot of lipid deposition in the vessels, causing the
Great.
stroke and the CAD.
Amazing. Absolutely right, sir. Absolutely right. Fine. So this is a Fabry's disease, right? So what's the diagnosis? It's Fabry's. What are the diagnostic criteria? We'll see, and treatment we'll see, right? So I'm interested in three things always in any MCQ. I don't need to make you the mug up guy. You just mug up the answer. It won't help you much. You need to understand. So Fabry's disease is a rare genetic disorder or condition caused by deficiency of an enzyme. What is the name of the enzyme? Again, a question in exam. Alpha galactosidase A. Alpha galactosidase A. Alpha galactosidase A. This is the exam question in DHA, right? So Fabry's disease, alpha galactosidase A, it's enzyme. It's not there in the body. Deficiency of this enzyme, as sir rightly told, there is a collection of lots of lipids in various vessels as well as in organ. So how the Fabry's present? So Fabry's disease can have various organ, includes heart, kidney, brain, right? Nervous system, they have painful burning sensation. Even they, it's a genetics, right? So even family history was also there. There is a dark red spots on the skin because that is also deposited in the skin. Decreased ability to sweat and GI symptoms. Cause means wherever they get deposited, you get a symptom, that's it. But these are the common one. Causes is what? There is a genetic mutation that affects the process of sphingolipids, leading to the accumulation in the blood vessel and organ. So blood vessel and organ, the lipids gets deposited, and this cause the all symptoms, right? And treatment is what? this enzyme is missing, alpha galactosidase. So you need to replace that enzyme. So enzyme replacement is the therapy, and rest of the thing is the supportive care. So Fabry's disease is the classical, right, of the symptoms. So answer is a Fabry's disease. Lyme's disease is what? Lyme's disease, you have a history of tick, you have a history of hiking and spiking in the United States, you have some this skin rash, you have a target lesions, right? Am I right or wrong, right? Target lesion you can see in the Lyme's disease, right? And there are primary, secondary, and tertiary type of Lyme's disease. Doxycycline is a treatment of choice, right? And in the second and third generation, there is a cardiac and neurological involvement is there in Lyme's disease, which is not here much. And there is a classical history of this hiking, trekking, and bites. Amyloidosis and myeloma is like amyloid fibril deposited in the body. Myeloma is a disease of bone marrow, right, where you usually get, right, high amount of plasma cells in the bone marrow, more than 10% of plasma cell in the bone marrow. You have kidney involvement, you have anemia, you have bone involvement, you have pathological fracture and hypercalcemia. So we called as a CRAB, calcium renal anemia bone. So we'll discuss sometime in hematology in detail as my primary subject. So myeloma will discuss. But concluding all the questions and symptoms, it goes in favor of these things, right? Because in myeloma, you won't have the family history of same maternal and grandmaternal, right? And there is a plasmacytoma, there is the anemia, so nothing is there. So amyloidosis and myeloma is less likely. So Fabry's disease, as I told you, so we end up with the 5 questions. Let's move to the 6 quickly. 44-year-old male with, so whenever you try to evaluate the things, so Fabry disease, I'm happy, right? Okay, fine, Dr. Toprak, you told me, right, Fabry's disease, I'm very glad. But same time, you need to exclude this. Why Lyme disease is, why not Lyme disease, why not amyloidosis, why not multiple myeloma? This is how you develop, right, lots of analytic skill in your brain and mind, right? So okay, fine, this is the things. And whenever you give the answer, say for example, you are given the Lyme's disease. So you need to ask yourself in the exam, is there any target lesion? No target lesion. Is there any history of spiking and hiking in United States or in rocky areas? No. Is there any bite history? No. Is there any joint pain? No. So this is excluded, right? Multiple myeloma, any pathological fracture? No. Anemia? No. High ESR? No. Plasma cell? No. It's not myeloma. That's it. So this is how you have to rule out others as well, not just the answer. So that would be even more stronger concept based learning for you. Next questions, very easy. Almost everybody will give the answer, hopefully. Let's see. A 44-year-old male with no significant past medical history present with a gunshot wound to the abdomen. On examination, BP is 65 over 44, heart rate is 125 per minute, respiratory rate is 22 per minute, oxygen is 95% on room air, is a stuporous, diaphoretic, and pale because of anemia, probably a lot of bleeding because of gunshot wound in abdomen. He has a bullet wound above the umbilicus that is bleeding actively. What is the best treatment to do for this patient? Are you going to do the emergency exploratory laparotomy, IV fluid, give pressure or vasopressor and blood transfusion? So how you approach? How you approach? What is the most important thing? Everything is, I think, all is applicable in this case. But what is the most important amongst all the 4 options which needs to taken care as soon as possible?
Immediate intervention is IV fluids. Immediate.
Yeah, but they are not asking immediate. See, this is a clue. This is very important. Let me tell you. I'll discuss this, right? Because this is, we knows, like we are doctors, we knows most of the things. We are treating the patient, but sometimes we get, if they ask you what is the initial treatment, it's a different answer. If they ask the base treatment, it's a different. So here they are not asking initial, they are asking the base treatment. If you have the all
Treatment
resources,
is,
what you can.
sorry,
Sorry. Yeah,
sorry.
you go ahead. I'm done. I'm done.
Best
They are
treatment
just
is
asking you.
exploratory laparotomy.
Laparotomy. Excellent. So I close my questions laparotomy. Why? Because until and unless you do the laparotomy, you are not going to find out what is the source of bleeding, right? So just giving the fluid doesn't stop the bleeding inside the tummy, right? So if they ask what is the initial, so obviously ABC, airway, breathing, circulation. Any emergency, this is emergency. BP is like 65, respiratory rate is high, right? Patient is heavily bleeding. pale, right? Actively bleeding. So this is a real life death emergency. If you don't do something in few minutes, probably patient may die because of hypovolemic shock or hemorrhagic shock because of heavy bleeding, active bleeding inside the tummy. That's it. So this is what the thing is, right? So you need to do the exploratory laparotomy. That could be the best closest answer for this. Obviously, IV fluid blood transfusion depends on anemia, 2 unit, 3, 4 unit, blah blah. We need to give undoubtedly. So this is exploratory laparotomy, blood and all. So I'm not going much in detail. So far, solved 6 questions. We are almost half the way, close to half the way. A third 3 months old baby. Next question. A 3 months old baby present with a rash that appeared on her face in the past week. It does not seems to bothering her too much. 3 months baby, and she has had no fever. Exam shows open and closed comedones as well as inflammatory papule, pustule, and nodules. So this is little confusing, but the beauty is that they given the diagnosis diagnosed as infantile acne. So this is all description of infantile acne. What is the treatment? So they have given the diagnosis. Now they are, and this is a visual these things, right? There is no specific test for infantile acne. So diagnosis you made on the visual base. Now they asking the treatment. So what the treatment of choice? Topical erythromycin, topical doxycycline, topical retinoic acid, vitamin A derivatives, azithromycin, vitamin C on a topical base. None of the above. That's fine. Everything is okay. Take your time. 15 seconds. Take your time. Yes, Hyral. Any comment? Dr. Hyral. Dr. Haifa, any comment? Dr. Haifa. Dr. Vidya Nair, any comment? Dr. Shafi, what's your comment?
Absolutely no clue about actual this thing. This is just guessing. I mean, I thought a topical antibiotic could be
Yeah,
this thing, but no
fine,
clue.
fair enough. Fair enough, fair enough, fair enough, fair enough. I'm happy. At least I'm happy you interacting with me. Great, wonderful. Right or wrong is not a big deal. It's a learning platform. Right, so basically this is infantile acne. Already they have said infantile acne. And what's the literature? Infantile acne, it's a benign condition. It is a benign condition, not a malignant condition. No treatment is required. Why? Because it is a self-limiting, usually self-limiting, self-resolving. No need to do anything. So answer is E. High yield fact, infantile acne is thought to be a caused by the exposure to a maternal hormone and can present anywhere between 6 to 12 months of age. Means before 1 year. This baby is before 1 year. 3 months infantile acne, you don't need to do it, dissolve by its own. So answer is none of the above. So go and check your answer what you have done. No need to do any erythromycin or so, because it's not infective things, it's a self resolving things. That's it. So answer is E. Let's move to the next question. 60 years old male present with severe dyspnea and is found on examination to have wheezing bilaterally. He says he has been intermittently unwell for 9 months with episode of severe watery diarrhea and flushing of his face and chest. On examination, CT scan of abdomen and pelvis shows a mass in the distal ileum and multiple liver lesions suspected as a carcinoid syndrome. So your job is easy. This is a classical case of carcinoid where the commonest site, just for your knowledge, statistically by literature, commonest site for the carcinoid is the GI tract. It is GI tract. That is why there is a lesion in ileum and livers. So it's a GI, part of GI. They usually present with the dyspnea. They present with the excessive perspiration and the diarrhea. So all everything is there. So now what their questions? So suspected is a carcinoid syndrome. Which of the following tests would going to help you to make a diagnosis or reach up to the diagnosis? Is it urine 5-HIAA, CT scan of chest, CT pulmonary angiogram, VQ scan or GI endoscopy, and you get the diagnosis. So what's your thought process?
So one of the most common cause for carcinoid syndrome is the lung CA.
Sorry, sir.
Most common cause for carcinoid syndrome is lung carcinoma.
Yeah,
I think
yeah,
so.
yeah, very common. We see in a practice. Yeah, you are right. You are right, sir. Lung is very.
CT CT chest scan could be better answer. That's the thought.
Dr. Rahul, any comment? Or Dr. Rahul Ranawat, any comment?
I think the answer would be urine HIA.
Okay, great. What is HIAA means? What stands for HIAA?
Hydroxyindole acetic acid, sir.
Excellent.
It's a metabolite of serotonin, basically. And
Excellent.
serotonin is released in carcinoid syndrome. So it is the diagnostic test, sir.
Excellent. Sir, you take a lecture next time. Huh?
Thanks.
I will be the audience. Great. So 5-hydroxy indole acetic acid, that is called 5-HIAA, 5-hydroxy indole acetic acid, is a urine test that measures the amount of this 5-HIAA, which is breakdown product of serotonin, right? And this test provides insight into how much the serotonin your body is producing, right? More serotonin, more 5-HIAA. It is often used to detect the certain tumors, especially carcinoid, and to monitor the person's conditions as well. So this is the test which is the thing. CT scan, chest, pulmonary angiogram. We are not suspecting any. This is pulmonary embolism. So CT pulmonary angiogram will not help. There is no clot anywhere in the body in this disease. VQ scan is again for that. GA endoscopy, right, will give you just the carcinoid. So they already given there is a carcinoid. They need to know by doing which state it confirms. So by doing GA endoscopy, you will not going to confirm. But by doing 5-HIAA, amount of the serotonin and end product and breakdown product of serotonin is 5-HIAA. If it is in a very high amount, you can know, you can make sure that this is you are dealing with some carcinoid tumor in the body. So 5-HIAA. So best initial test is 5-HIAA, as it is already told. Elevated level suggest a presence of carcinoid tumor. Right. Again, another test you can do it. Octreotide scan is also available nowadays. We are doing for our patient. First line treatment is surgical resection if it is a localized disease, and chemotherapy, radiotherapy, and octreotide for symptomatic relief of the patient. That's it. So this is what the thing is. 8 questions so far. You check your score. 8 out of 8 is a brilliant score. 9 number questions. You are called to house 69 years old female whose neighbor came to visit and found her unable to speak without slurring her words. You arrive to find an elderly female seated on the couch, appearing very frightened. She attempts to talk, but is unable to appropriately talk to you from her words. The neighbors is present who does not know the patient's past medical history. Patient's blood pressure is 126/78, respiratory 18, oxygen 98, room air, pulse 76, bit irregular. What's the most important amongst the below options? Right? What you do not resuscitate status as it is. What was the last time the patient was seen without symptoms? The phone numbers of the relatives is important, or what medication does the patient took, that is important. So basically, again, try to understand the questions. You are called to house. I'm a doctor. Somebody called me. Somebody means who called me? 69 years of old female, right? Whose neighbor came to visit and found her unable to speak, right? And you arrive to find the elderly female seated on the couch, appearing frightened. Vitals is this, unable to talk properly, right? And past medical history is not known because neighbor is new. I am also being a doctor new. Patient found in this condition in the house. So what would be the best? What would you do for this patient? So first diagnosis, again keep a triad of mind in. So try to make some diagnosis. What could be the diagnosis of this patient? Sultan.
Because it's important things is anonymous, and I want to learn patient's story.
Yeah. So what could be the diagnosis? Possible diagnosis. See, Whenever
Hello, sir.
any
Dr.
MCQ
Abhishek
you
here.
come occur, let me finish. Sorry.
This could be,
Whenever you read
so
any
this could
questions,
be
you need to have a one questions in your mind that what could be the diagnosis. Let me tell you very honestly, without the diagnosis, it is very difficult for you to answer any questions. So diagnosis, investigation, treatment. Don't break this my triad. Believe me, it would going to help you a lot. So first make some clinical diagnosis what this patient is likely suffering from. Now go ahead. Anyone.
Sir, hello, Dr. Abhishek here.
this could be
Uh, he's
Yeah, Abhishek.
the lady is suffering from the CVA stroke, that is the upper motor neuron disease.
Right. Okay. So in CVA stroke or stroke patient or suspected stroke patient, right? What you want to do? What information is very important amongst this A, B, C, D?
Any previous
so
history of stroke? Any previous history of any heart disease?
Fine. So that is not there. Say for example, it is not mentioned much, but it is not there. So what is the most important information amongst these all options?
sir,
Because now you
in
are
this patient
suspecting
especially,
stroke, right? So you need to do
yes,
something for this
When was
patient.
it last time a patient was seen normal?
Exactly. So that is the most important thing because you need to know because stroke treatment, what is the most important thing in a stroke treatment is a time frame, right? Right. So this is what the thing is. Let me first give. There are five things, six things, right? Which we know, right? Be fast, right? Be fast. So facial arms means unable to raise the hand, unable to raise the hand because of stroke. Facial asymmetry. Speech is not normal or slurred speech. Time is important, right? This is a balance and right. So sometimes balance is also gone. Sometimes patient present of stroke with balance loss, unable to balance well, right? Or they may present with eye symptoms as well or diplopia, I mean, reduce the vision. That is again a symptoms of stroke. So be fast or fast. Fast is the commonest, this acronym. Facial asymmetry, right? Arm drift or arm weakness, slurred speech or difficulty in speech, and time is important. Why? Because the management is less than 3 hours is called as a golden hours. 3 to 4.5 hours is borderline more than 4.5 hours. This is the absolutely time frame. So you must know when the first symptoms was started. If somebody tells me a stroke patient that I since night 8 o'clock I had these symptoms and morning 8 o'clock he present to me or she present to me in emergency more than 12 hours, my absolute mindset will change for the treatment of stroke. Right, 80% of stroke are ischemic stroke, 20% are hemorrhagic. So 4 out of 5 patients are ischemic stroke, but still we need to rule out with the CT scan. Still we need to rule out with the CT scan because if it is a hemorrhagic stroke and you are giving aspirin, clopidogrel, TPA, then you are killing the patient because already hemorrhage inside. You are giving the blood thinner, patient will die immediately. Right. So first, so how it works? First the symptoms. Right. So symptoms of stroke. These are the 4 symptoms. Any patient you see 3 symptoms: facial, arm, and speech difficulty. Think of stroke. Once you suspect the stroke, as soon as possible you do the CT scan plain. You don't need the contrast CT scan. Don't waste time doing the contrast because plain can differentiate between hemorrhage and ischemia, right? So you want to just rule out it is not hemorrhagic stroke. So you did, there is a stroke, there is a ischemic stroke, there is no hemorrhage inside your brain, ischemic stroke, and then the next question is time frame. What time the symptoms develop? If it is less than 3 hours, you give TPA, right? 3 to 4 point hour borderline. Still, you try to TPA anything more than 5. You just give the blood thinner like aspirin and clopidogrel. That's it. This is what the management is. That is why we need to know what is the time frame or when was the first symptoms was started. Without that, it is not a good idea to start treatment blindly or randomly. So amongst this suspected stroke patient, you need to know that okay, fine, when the symptoms was started, and that is why the answer is when was the last symptoms started. That's it. DNR, there is no meaning of DMR now. Do not resuscitate. Patient is not dying anyway, right? Or it's not good idea DNR at this live patients. Phone numbers of relative is not much important. It can be done later on. The most important is when even patient nobody is home. No? They are saying home. There is nobody at home. So patient relative even don't know at what time this lady is sitting in the couch with the symptoms of stroke, right? And what medication does the patient took? So not much helpful, right? Stroke is there. Absolutely, stroke is there. Irrespective of medicine, stroke is there. So you now need to know, right? Ischemic or hemorrhagic, first thing, and what's the time frame. That's it. So you need to go the treatment to the patient. So that's it. This is what the thing is. I already discussed every part. Last few questions, bear with me for more time, 15 minutes. Male, next question, 9 out of 9, whatever the score, you just keep in mind. Question number 10. Male came to you complaining of sudden progressive decreased vision of left eye over last 2 to 3 days. Also pain on the same side. On fundoscopy, doing the fundus examination by ophthalmoscope, seen optic disc swelling. What is the likely diagnosis? So diagnosis is what, treatment is what. This is my two questions. Central retinal artery occlusion, central retinal vein occlusion, optic neuritis, macular degeneration, none of above. Take your time. You need to do some brainstorming. You need to know everything. What happens in central retinal artery occlusion, what happens in central retinal vein occlusion, what happens in optic neuritis, what happens in macular degeneration. So you need to have little clarity about this. This is a very common, very frequently asked question. Yes, we are more than 40 people in this meeting now, and answer is only 2 or 3. Post anything, whatever. Think that if the same questions comes in your exam, how you answer? You need to answer. And one more advice, don't keep the questions blank in the exam. Fortunately, there is no negative marking in DHA or any Middle East country. So whatever you know, you put some answer. That's it. Yes, Dr. Ali. Dr. Ali, any comment, Dr. Ali? Yes, Dr. Talat Munir. What's your comment?
Sir, this is a topical case of optic neuritis.
So what point favors optic neuritis? What point favors in this case of optic neuritis? An optic
Sir,
neuritis
it's
patient comes to you. Yes, tell me.
yeah. It's an acute inflammatory demyelinating injury, sir.
Okay, wonderful.
It's peripheral visual loss, monoocular peripheral visual loss here, and painful eye. It's all the characteristic of
Excellent.
optic
Excellent.
neuritis.
So pain is most important thing as well, right? So this is optic neuritis, right? This is the picture of fundus, maybe normal fundal examination in 60%. Optic swelling, optic neuritis. So there is a optic nerve which supplies the eyeball from the back side, right? So there is an inflammation, as sir absolutely told well. It's a demyelinating disease, blurring of the disc and swollen retinal veins, right? Because of inflammation. So optic neuritis is a demyelinating inflammations of the optic nerve. So here see normal optic disc, right? See, this is a nice picture. I got it. So here car, you can see the car Lamborghini. It is very clear cut. And what seen in the optic neuritis, it is very blurred picture. Here the normal optic disc is an edematous optic disc, right? Because of inflammation, edema. Clinically, sudden loss of monoocular means single side, because there is a right eyeball, right optic nerve, left eyeball, left optic nerve. So it's not bilateral, right? And there is a vision loss because of inflammation, pain with the movement on affected eye. So this is extremely important, pain, right? And the loss of color as well, especially the red. So see the things, and that is the called as a youth of phenomenon. That's fine. And etiology is what? Where, which are the condition where you get the optic neuritis is multiple sclerosis, the most common. So any patient you diagnosed or your ophthalmologist diagnosed as optic neuritis, never ever miss the multiple sclerosis. Try to chase the multiple sclerosis. I had already given you the homework in motor neuron and ALS, amyotrophic lateral sclerosis. Go and read. GBS, Guillain-Barré syndrome, multiple sclerosis, syringomyelia, and this motor neuron disease, right? Infection with the Lyme's, herpes, and syphilis can end up with optic neuritis, autoimmune disease, right? Neurosarcoidosis and lupus. Methanol poisoning. Methanol is like we have in our Indian part. There are a lot of patients using this high amount of alcohol, and they end up with acute sudden visual loss, that is optic neuritis. B12 deficiency and diabetic retinopathy, and management is corticosteroid. For optic neuritis, you need to reduce the edema surrounding the optic nerve, so it will improve the pain, it will improve the vision, it will reduces the symptoms. That's it. So it is acute inflammatory demyelinating injury or inflammation to the optic nerve, and resulting in this treatment is steroid. 10 questions done. Last few minutes. Question number 11. A 5 years old boy is noted to be a fatigued and lethargic in class. His school teacher observed that he has a beefy, swollen tongue, and the school nurse calls your office. School nurse calls your office because he is febrile. The nurse says the boy's skin feels coarse like sandpaper, his tongue is like a strawberry. Upon examination, you find that the child's rash blanching easily. There is no desquamation of his lips. Which of the following next step in the management of the patient? So again, let me come to the basic. Before management, you need to make entire diagnosis. So first to make a diagnosis, then treatment or management would be far easier. But here they had not given the diagnosis. So try to create an impression of this question. What could be the diagnosis? Okay. Yes, Hiral.
Yes, sir.
It's not a, yeah. So how you differentiate Kawasaki with the scarlet fever?
So I have a confusion with the strawberry tongue between Kawasaki and scarlet fever.
Right. So whenever S for S, scarlet is a sandpaper is a scarlet, strawberry is a scarlet. So fix in your head, this is a scarlet, right? Not a Kawasaki, right? So scarlet fever is an infectious disease. Kawasaki is a kind of autoimmune disease, little different disease, right? So that is why probably you got confused. So this is a scarlet fever, right? And treatment is a antibiotic because it's a infective etiology. So it is a classical. Let me show you the pictures as well. I gathered few pictures as well. So this is symptoms of scarlet fever. You have on the chest. This is a common on chest head and neck part. White skin rash looks like, and the strawberry tongue, right? So strawberry tongue is again a strawberry tongue. Can you see? It's a hallmark of scarlet strawberry. Remember in that way, right? And also redness or rash, right? So this is the classical for scarlet fever. And what is this scarlet fever? So scarlet fever is infectious disease. Scarlet fever is an infectious disease caused by Streptococcus
Why?
pyogenes that present with the sore throat, strawberry tongue, sandpaper skin, and the rash is in the inguinal areas, axillary, blah blah. And there are specific lines called as a Pastia lines. So if they are sometimes give you the example, the Pastia's line skin, what is the diagnosis? Pastia line. You go and little Google it because of time constraint. I'm not going much in detail of Pastia line, but this is a signs of scarlet fever. And what's the biggest complication of scarlet? Why you are worried about scarlet? Why you want to treat the scarlet in early phase? Because of acute rheumatic fever is a complication, and glomerulonephritis. So heart and kidneys are affected. If you don't treat this infection, streptococcal nephritis and streptococci can damage the heart valve, acute rheumatic disease. So you should give the antibiotic as soon as possible. And the choice is a penicillin is the best treatment choice. So here, go back to the questions, right? So this patient has a scarlet fever, diagnosis is scarlet, and treatment is a start antibiotic, right? Culture will give you the diagnosis. Again, you want to manage this patient, so
Why
you given
not
the
do
diagnosis.
the
Sorry, sir.
starting
Sorry,
about
I cannot get your voice properly,
purpose?
sir. What's the question? Right? So order blood culture is not appropriate thing. Start IVIG. IVIG again, Dr. Iral. This is a kind of Kawasaki, not in the scarlet. Checking
Why
ESR
don't we
does not
check
help
for like
because, yeah, checking ESR will not help.
question?
It's a
Why
very
don't we
non.
do? Yeah.
Sorry, sir. What's the question? Sir, what's the question? I cannot hear you, please. Okay, so it looks like no question. So observation is not good idea because it's an infection, so you need to treat it. Dr. Iral, you got the idea, right? You understand
Yes,
what
sir.
I'm trying to explain? Wonderful. So this is what the thing is. So just keep in mind when there is a scarlet, remember 2S from my side. Sandpaper skin and strawberry tongue. That's it. Strawberry and streptococcus. All S. Scarlet, streptococcus, strawberry, sandpaper. That's it. Antibiotic is the treatment. Now it's easy now.
Yes, sir.
Wonderful. Next questions, last two questions. I compiled 15 questions, so next 10 minutes all done. So just bear with me. 64-year-old woman with type 1 diabetes present to the clinic with several months of sinus problem and 4 days history of oliguria means less urine. Her blood pressure is 137 over 80. Serum result shows mild elevated urea and creatinine in absence of anti-GBM antibodies, while CNK assay is positive. Red blood cell casts are present in the urine, and her renal biopsy shows glomerular crescents. What is the most likely diagnosis? Very interesting. Post-streptococcal glomerulonephritis, good pasture syndrome, minimal change glomerulonephritis, rapid progressive glomerulonephritis, and Wagner's granulomatosis. Take your time, 15-20 seconds. Yeah, post the answer. We are still 40 people. Few people probably get hungry, so they may left. Yes, Dr. Safi, any comment?
I'm not quite sure about the answer, but I can say that because there's no anti-GBM antibodies, it is not good purchase syndrome.
Okay, fair enough.
Sir,
And why it's
sir,
not Wagner?
Wagner is right.
Because it is
Yeah.
showing crescents, maybe it is due to rapidly progressive glomerulonephritis.
Rapidly progressive. What is the cause of rapid progressive glomerulonephritis? And do you see in rapid progressive CNK positive?
No, no.
CNK positive in rapid progressive?
I didn't see that.
Great, no problem. That's fine.
Okay,
For the
Vignesh.
learning plan. Yeah, so this is Wagner. Listen, Wagner. What is the Wagner basically? So we need to understand nasal sinus. So there is a sinus problem. They have given in the first, right? Sinus problem. So this is a sinus, this is the airways, this is a lung, and this is the kidney. So Wagner granulomatosis is an autoimmune disease that causes inflammation of the blood vessel, or it's a vasculitis. I will take you to the type of the vasculitis very soon in next slide. Wagner granulomatosis commonly affect the upper respiratory tract, that is the sinus, pharynx, larynx, blah blah. That is upper respiratory. They affect the kidney and lungs as well, right? And it can also affect other organs also, but it is not as common, right? So primarily the upper airway, lungs and kidneys gets affected. This is absolutely nice classification. This is little better classification. If you suspect glomerulonephritis, if hematuria and proteinuria and or hypertension, fluid overload, elevated creatinine, this is just excellent picture. I got it from internet only. When I was studying my PowerPoint to present you, I was doing a lot of research before presenting to you on every Sunday. So I got nice slide. So you have everything. You have hematuria, proteinuria, hypertension, high altered renal function. First and foremost is see the serum C3 and C4 complement. Low C3, C4 what? Normal C3, C4 for. So here normal C3, C4 not mentioned means normal. Obtain ANK and GBM if pulmonary or systemic manifestation. Yes, right? So if GBM positive, this is good pasture. GBM is not positive and ANK is positive, then it is a granulomatosis. That is Wagner. So you can have this chart with you. I will share this PowerPoint, and this is again, but it looks little complicated to me. So I like this chart, probably easy to understand, right? So Wagner's granulomatosis is the things, right? So next questions in front of your screen. 4 years old child is brought by her mother because of red spot and rashes on her lower extremity. Today she fell from this bicycle and was bleeding for 30 minutes. She has no known medical problem, and only significant history is upper respiratory tract viral infection. Examination reveal patek in lower limb and buttock and purpura on buttock. There are no signs of active bleeding. PT, APTT and bleeding times are within normal limit. Platelet count is 32,000. Hemoglobin is 12. What's the next step in the management or workup, or what could be the best thing? Are you going to do the bone marrow biopsy? You do the factor level, factor 8, 9, 10, 11, hemophilia, blah, blah. Mixing study, peripheral smear review, or ristocin assay or test you will going to do. I need four answers. What all, where the all tests are done. What are the condition in which ABCD is done? Number one. What is the treatment of OBO condition? So first of all, you need to make a diagnosis. My triad again. Diagnosis, investigation, treatment. So you need to make a clinical diagnosis. So your job would be easy. So what is the treatment? So once you know the diagnosis, then you better answer this question. What antibody found in above condition that you need to know, and when the ristocin assay can be done. So take your time. It's little easy as well as complicated. Think over it. Yeah, so what's the comment? Anyone? Any volunteer? Anyone?
It could be ITP.
ITP. Wait 1 second. Huh? Just we'll discuss in 1 minute. Yes, anyone? Dr. Abhishek, why it is HSP? Dr. Abhishek.
Sir, because there are the like purpuras.
Okay, 1 second. Let me open up the question. So first questions to you. Is platelet is normal in HSP or decrease in HSP?
Sir, decrease in HSP.
Okay, are you sure?
Sir, not so pretty sure.
Okay, so just for your knowledge, HSP platelets are normal. Go and read the HSP once again.
Okay,
HSP
okay,
is
sir.
it's a vasculitis. You can get the purpura, you can get the petechi, you can get the blanching petechi, blah blah, right? But the platelets are normal. So this is biggest difference between ITP and HSP or other things, right? So you go. HSP is again a very high yield topic and frequently asked question in exam, right? So it's not HSP because in HSP platelets are normal, here low. So HSP is absolutely gone for your knowledge. Okay,
Okay, sir. Okay.
fair enough. Right. Anyone? Anyone? Yes, Dr. Sandra is saying HSP, purpura, abdominal
Yes, this
pain,
is
arthralgia. That's
ITP.
correct. Yeah,
Uh,
ITP. So, okay, fine. Great. ITP. So now what is the next step, right? In the ITP, what
Peripheral
you
smear.
what
We'll do
pe-
we'll do the peripheral smear and look at the platelets. The
oh,
platelets should be large size,
platelet should be large size. Okay, fine. Fair enough.
megakaryocytes.
No, megakaryocyte will not see, sir. Sorry, in peripheral smear.
As
Megakaryocyte
in
in the bone marrow.
bone marrow.
So yeah, so I understand you are going right, but just for your knowledge, I'm hematologist. So I'll just give so peripheral
Okay.
smear is the most important first step. What is this is called peripheral thrombocytopenia or peripheral destructions of the platelet, right? By antibody mediated, right?
Yeah.
So antiplatelet antibody is there, antiplatelet antibody, and classical thing is upper respiratory tract infection. So any child, right? It is commonly seen in a child. So any child coming with upper respiratory tract infection within 2 to 5 days or 6 days, they present with the thrombocytopenia, some bleeding, some petechi, purpura, hemoptysis, nasal bleed, blah blah, hematuria. It's a classical platelet bleeding. Thrombocytopenia is because of post-viral suppression of bone marrow, thrombocytopenia. So if patient is not bleeding, you don't want to do anything, you just wait and watch. It will resolve by its own. That is the treatment. That is how we treat in a day-to-day practice. But when the patient has a bleeding with low platelet, you must have to treat it, right? So bone marrow biopsy is not a good idea, right? At this point of time, and bone marrow biopsy is mainly done in low platelet to exclude the other uh, the disease like leukemia, lymphoma, aplastic anemia, blah blah. Right. So these are the few other diagnoses of bone marrow which you don't want to miss in low platelet. That is why bone marrow is. But this is classical case: child, upper respiratory tract infection, thrombocytopenia. That's it. For this, you don't need a bone marrow biopsy. Factor levels are not at all indicated. Why? Because PT, APTT is normal. Primary screening clotting this test are normal, so factor not required. Mixing studies done for those patients where PT or APTT is high, where you want to know whether it is a factor disease or it is a this disease. Factor, this is because of factor or this is because of inhibitor like glucose anticoagulant and anticardiolipin antibody. So PT and APTT, if high, then you do the factor level as well as mixing study, otherwise not required, and ristochin is not required. Peripheral smear will give you the idea that okay fine, this is a peripheral thrombocytopenia, platelets are large than normal, and megakaryocytes are increased in number in the bone marrow. When you do the bone marrow, it is not normally seen in the peripheral smear. You just see the red blood cell, white cell, and platelet in the peripheral layer, and you can see the morphology of the all three cell lines under microscope. And peripheral smear is the number one investigation for any cytopenia. Forget about this thrombocytopenia. If it is leukopenia, do CBC peripheral. If it is thrombocytopenia, because peripheral smear will give you the idea about lot more other disease as well, along with the platelet morphology. So peripheral smear is an important test. So we must do the peripheral
Sir, I have
smear.
a question,
So this
please.
is sorry, sir. Any question, sir?
Sir, why is the bleeding time normal in this patient? Why
Bleeding
is the
time.
bleeding time normal in this patient?
Bleeding time can be a normal. It is not mandatorily that every time the bleeding
Yes, sir.
time is high, right? So it is not always seen. It could be high, it
But
could
if
be
the
low.
platelets are being my concept was that if the platelets are low, then it affects the bleeding time. So is it the same or is it something different? I wanted to understand.
No, no, I understand. It's a very good questions rather, right? When so basic logic is that when platelet is a primary things and factors are secondary coagulation if you go for the physiology. So the bleeding time is, it can be a normal. It is, I'm not saying it is always normal, but it could be a normal, it could be a high, right? But bleeding time usually gets abnormal in thrombocytopenia as well as platelet functions disorder as well, like von Willebrand disease where bleeding time is high, right? So it could be normal, it could be high. So it is not mandatory, it should be high, right? And rest of the things are clear cut, PT and APTT. But this is classical, I mean,
Okay.
irrespective of even bleeding
Thank you,
time,
sir.
right? This is remember three things. Anytime when you want to diagnose the any low platelet or any platelet patient comes to you, what the question you need to ask yourself, right? What is the history? At children, upper respiratory ITP. Second thing, patient low platelet, hemoglobin white cell normal, it's ITP, irrespective of age, right? If hemoglobin white cell platelet all three low, then forget about ITP. Think of leukemia aplastic and myelodysplastic syndrome. You understand? So here hemoglobin is normal. So you need to compile a questions as a whole. You can't rely on the one factor. You need to see history, examination, other clotting factors, PT, PTT, platelet, blah blah, right? So this is called as isolated thrombocytopenia, isn't it, sir? It's isolated thrombocytopenia. Only platelets are low, and commonest
Yes, sir.
condition for only low platelet is a ITP, right? So I'm not going much in detail of
Yes, sir.
things.
Thank you for the
I'm just
explanation,
going
sir.
to, no problem, sir. So basically, ITP is an autoimmune disease. As I told you, it's antibody mediated. GP2B and 3A. This is the name of the antibody, right? So in ITP, this is most important thing is a treatment. So present, right? No bleeding and platelet count is more than 30,000. As I told you, if the patient, see, we are not going to treat, being a clinician or hematologist in my practice or anybody, not me, any hematologist practicing, they are not treating on the numbers, they are treating on the numbers plus symptoms. So if the, say for example, if I tell you what is the, what at what HB the transfusion can be given and what HB transfusion can be not given. So it's a little easy but very difficult question. Somebody says, sir, below 5 we give, below 6 we give, somebody say below 7 we give, somebody say below 8 I have to transfuse. So what is the cutoff line for transfusion? So what the thing is, if the patient is symptomatic, if patient is symptomatic for the anemia, he is the right candidate. So say for example, I have a young lady of 20 years, very young, 20 years girl, presented with 6 grams of hemoglobin with iron deficiency. I will not transfuse, right? But I have a 60 years of male with triple vessel disease and hemoglobin of 7.5. I probably treat with the transfusion, where 6 and 5 gram I am not treating at 20 years young. Etiology is different, diagnosis is different. So number is not the criteria, symptoms is important, right? So bleeding more than 30, I mean no bleeding and more than 30,000 platelet, just wait and watch. Don't get panic, don't start steroid, don't give IV platelet, right? Just wait and watch because patient is asymptomatic, no bleeding, platelet counts are good. What if it is a bleeding and platelet counts are low? Then glucocorticoid, this is the most important thing which you must remember. What is the first line treatment of ITP? Answer is glucocorticoid. Second questions, every time every student get confused. What is the role of IVIG and NTD? So remember two things. 2B I remember, brain and bowel. B for brain, B for bowel. So when there is a excessive or when there is a massive bowel bleeding, means GI bleeding or brain bleeding with ITP, you need to give IVIG and NTD. That's it. This is the simplest way to remember, right? So if the no bleeding and platelet high, no treatment. If bleeding and platelets even normal, I mean even more than 30,000 you must treat, less than 30,000 definitely treat because of this thing. But say for example there are 40,000 platelet and patient is bleeding, you probably give the steroid. Massive bleeding, bowel and bladder, brain, sorry, brain and bowel, give the IVIG and NTD. If patient does not respond to steroid, next immediate treatment is a splenectomy. And now the thrombopoietin antagonist comes in the market. We are using it. That is romiplostin and L-thrombopag are the drug which is available in the market. So if some patients given steroid, no response, you advise for splenectomy, but they don't want to go for operation. This drug romiplostin and L-thrombopag you can try it off. If they get fail, you can go for the splenectomy. That's it. So this is what the tips is. So what's the tip? ITP is a diagnosis of exclusion. So you need to rule out one by one. This is not von Willebrand. This is not viral. This is not HIV. This is not HBsAg. This is not leukemia. This is not lymphoma. This is not myeloma. This is not aplastic. and long list for me. So ITP is a diagnosis of exclusion. You exclude everything and then finally, okay, everything is fine. It's ITP. That is called diagnosis of exclusion. ITP has no hepatomegaly lymphadenopathy. Usually, very rarely, you may see splenomegaly, very rarely, because of spleen destructions of the platelet in the spleen. ITP only low platelet in CBC, large platelet, as I told you, and increased megakaryocyte in the bone marrow. And ITP, the first line treatment is a steroid. 70-80% patients achieve complete remission forever. So that's it. This is what the thing is. Last two questions, picture questions. This is how it comes in your exams as well. There is no clue. This is the picture. You need to tell what it is. Lead poisoning, iron poisoning, copper poisoning, acute myeloid leukemia, M5 subtype. That is called myelomonocytic leukemia, and none of the above. Yeah, post your answer. So now onwards, little concentrate your eyes on the pictures as well, because they many a times ask picture MCQ as well. Yes, Hiral, any comment?
So I'm not sure.
Random guess, don't worry. It's a learning platform.
It
If you
might
see,
be C.
if you are going to the patient's house and see, and patient showing, sir, see, can you see, doctor, my teeth? What is this? You need to
It might be C. It's not B for sure.
not be means iron poisoning is not there. Okay. So you are
Yeah.
confused between what?
C and
C and
C, I guess.
C. So what you see in a copper poisoning in the teeth, that is your homework. So go tomorrow or go today. Time frame is different, probably in your country, my country. So you see earliest whenever you stable, right? What is the changes in the copper poisoning? What happens in the skin? What happens in the liver, kidney? Where it gets deposited? What problem patient may present with? What's the treatment? If the copper poisoning is there, what's the treatment? So it's a homework. Read it. You will improve your knowledge. It probably helps you. So answer is lead poisoning. So this is a lead poisoning classical. The blue lines evident on the gums are the Burton's line, which can be present in the patient with lead poisoning. Diagnosis of occupational lead poisoning was confirmed by the elevated serum lead levels. Patient recovered following chelation therapy, blah blah. So anyway, this is a lead poisoning where you can see such classical things. So I got it pictures. What is the treatment of lead poisoning? Anyone, open for all? Any agent, chelating agent for lead poisoning? Anyone? So this is again a lot of questions. What is the iron poisoning? So if excessive iron in body, how you remove the excessive iron from the body? What's the iron chelating agent? What is the copper chelating agent? What is the lead chelating poison? One question will definitely, yeah, doctor, you have told chelating agent, but I want to know the chelating agent name. Succimer. Somebody is saying desperioxamine. That is probably for the iron, not for the lead. Right? So you need to know all the three. That's the homework for you. I will ask you tomorrow. Last questions for today, and then we'll get little feedback. Short history, picture diagnosis, spot diagnosis, history of immunocompromised state. More detail if I can give you, this patient is HIV positive. You got this lesion, right? What could be the diagnosis? So I given you the very fair idea about immunocompromised, specifically HIV. Squamous cell carcinoma, basal cell carcinoma, Kaposis sarcoma, malignant melanoma, none of the above. Great. So most of the people, doctors, is giving the perfect answer. It is not a melanoma, right? It is a whenever there is a melanoma, you need to know A, B, C, D, E. Asymmetry, border, color, diameter, dimension, right? So this is a classical in HOA, that is a Kaposis sarcoma. Kaposis sarcoma. So Kaposis sarcoma is a cancer forms in the lining of the blood vessel, right? So you can see there is classical lining of the blood vessel. It is usually seen in the face, right? In Kaposis sarcoma, if you have seen the HIV patients or worked in OPD of HIV, you may see a lot of sarcomas of Kaposis. Is a type of cancer that forms in the lining of the blood and lymph vessels. It leads to the development of growth called a lesion on the skin. The lesion can appear on the face, arm, legs, genital, and mouth. May vary in the color, ranging from pink and red to purple or brown. If you have any further question, blah blah. Fine. So this is what the description is, and treatment of Kaposis sarcoma. It is localized at one place. You can burn it with the radiotherapy, cryotherapy. These are the commonly used, and systemic therapy, antiretroviral, and paclitaxel is the chemotherapy. Gemcitabine and interferon is the treatment of choice. Thank you very much for your kind attention. That was my presentation. I tried to compile it in exactly 1 hour and 37 minutes. So that's all. Hopefully you enjoyed the lecture. You understood the concept, how to crack the MCQ, what's the important triad, diagnosis, investigation, treatment, probably new for you. But if you cultivate the practice of this triad, I'm I can give you the guarantee, whatever they ask in exam, you are 100% pass. 100%, not 99%. But you need to do little exercise. Last but not the least, before leaving the class, I want two people at least who joined the first time the class of me. I want to hear from them what's the experience. Anyone? I know a lot of people who joined 5 times, 10 times. Not a, I want first time who joined. How was their experience? I want to know.
Hello, sir.
Sir,
Yes, doctor. Yes, I can hear you. You go ahead, doctor.
Hello, sir.
yes,
Today is first class,
Yes, yes. Go ahead, doctor. How was
and
your experience? You explain in your own word.
this is very good explanation, sir. And
Okay.
it is very useful for me and to decide how to prepare and all those things. It's very good.
Very nice. Excellent. So you get little idea that, right? How to approach the questions and all, blah
Yes,
blah.
sir.
How you explain.
Then I scored 11 out of 15, sir.
11 out of 15. So it's a brilliant score. Let me tell you, it's a brilliant score, not bad. So
Thank
probably
you.
in 1 to 2 months, you are probably ready to go for the exam.
Thanks.
So
Thank you so
that's
much.
it. Anyone else? Thank you very much, doctor. Anyone else? Anyone more? So nobody joined first time today. Everybody we are almost close to 40,
Thank
50
you
doctors.
so much, dear sir. Me, Dr. Asmat from Afghanistan. It was very useful, highly effective, really helpful. Thank you so much, dear sir.
Wonderful, sir. Thanks for your motivation. So, okay. Thank you very much once again. Joining, you can post your little review and feedback in our free trial test as well. So other people also get motivated. So just keep in touch. Get ready with the next lecture on the next Sunday. I will publish and announce in advance. So prepare well. Best of luck for exam going and keep in touch with me. Feel free to call me. Unfortunately, Dr. Afrin is a bit busy somewhere, so probably not joining for EMRI, but we will organize the full-fledged seminar or webinar on EMRI exam soon. So just wait for some time. We'll come up with a proper webinar like this only. So me and Afrin will going to guide you for residency exam in Dubai. Thank you very much.
Doctor, can I ask you a doubt?
Yes, please.
Doctor, what is the pass percentage for OMSB examination?
60% minimum, higher the better. You need at least 6060.
Okay, sir.
But keep a
Okay,
goal
thank
of
you, Doctor.
70. Right? Yeah, higher the
What
better.
will be the total number of questions, Doctor?
OMSB, I think latest one is 150.
Okay.
150. Hello.
Okay, thank you, Doctor.
Okay. And if you have any questions, any queries, you directly connect with me. This is my number. If you can see this number 98255 here, this is my number, right? Dr. Munjal. So you can directly approach me. Okay, thank you very much and enjoy your Sunday. See you on the next Sunday with another mock. Thank you. Good day. Bye bye.